Okay, why don't we go ahead and get started? Good afternoon, everybody. I'm Patricia Stone, or Pat Stone, as most people call me. I direct their Center for Health Policy here at Columbia School of Nursing. I'm really excited about our panel today in this event, Improving Care Quality for Older Adults, the Health Policy Landscape in 2024. Everybody's on a webinar, so feel free to use the chat feature at the bottom of your screen to ask questions, and we'll address them at the end of the program. And really happy to introduce our exceptional speakers. As a note, each speaker's full bio will be put in the chat so you can learn more about their incredible work and accomplishments. First, I'm going to introduce our moderator, Dr. Poki'i Balaz. She's a public health executive leader who's dedicated her career to advancing health initiatives through innovative strategies in healthcare policies and systems change, with an emphasis on aging and advocacy for underserved and aging populations. Using both her clinical and leadership abilities, she addresses critical healthcare issues and advocates for the improvement of public health and the welfare of marginalized communities. She's a board member of the Alzheimer's Association Leadership Board, recipient of the Alzheimer's Association Advocate of the Year Award, and was selected to be part of the Obama Foundation Scholar Program. Our panelists are Tara Cortes. She's who's recognized for her distinguished career spanning executive leadership, nursing education, research, and practice. She is currently the executive director and professor at the Harvard Institute for Geriatric Nursing at NYU Rory Myers College of Nursing. Dr. Cortes has provided significant contributions to advance the health of older adults, particularly those who are frail and vulnerable with limited access or voice in our healthcare system. And she's developed a collaborative interprofessional models in traditional as well as non-traditional settings to enhance the health and quality of life for our aging population. And then last, but certainly not least, is Brynn Bowman. She's the Chief Executive Officer of the Center to Advance Palliative Care, CAPC, and presides over the organizational and content strategy that served more than 1,700 CAPC member healthcare organizations, including over 70,000 clinicians and administrators. Ms. Bowman has expertise in palliative care business and finance, program design, and education for non-palliative care specialists. Ms. Bowman is nationally recognized leader in scaling practice and culture change in healthcare delivery for people with serious illness. Now, I'm going to pass it over to Poki'i. Thank you.
Thank you, Pat. I'm very excited to be here with all of you today and just want to say to all of our participants, welcome. Thank you for making the time and joining us. I guess we can jump right into it. There's so much to say here, and we definitely want to hear from our speakers. So let's begin. Tara and Brynn, what are some of the models of care for the elderly that are positioned in CMS right now and that are driving change in access, quality, and payment?
Do you want to start, Brynn?
Sure, I can jump in. I sit in the serious illness world, coming from the Center to Advance Palliative Care. Some significant news came out last month. CMMI, the Center for Medicare and Innovation, announced that they're going to be discontinuing the testing of the hospice carve-in inside of the VBID model. That's the value-based insurance design program. So that was a program that was launched in 2021, scheduled to run through 2030, and that the hospice carve-in inside of VBID was shuttered came as a surprise, I think, to a lot of people. So Poki'i, you had asked about changes in payment and access, and this is what I think we'll see, whether it's a change that limits access or goes the other direction. The aim of the hospice carve-in had been to reduce fragmentation in care at the end of life, but Medicare Advantage orgs had real challenges operationalizing how to deliver the appropriate palliative care services along a spectrum of intensity of patient need, up to and including the end of life, and making the finances work accordingly. So I think that was one challenge that a lot of participants in the VBID model faced. And the other was that Medicare Advantage organizations typically create fairly narrow provider networks. So that created access challenges for patients and contracting challenges for hospices. So a big shift. The aims of that program will important, and I don't doubt that there will be future attempts to crack this code in terms of hospice and end of life care, but this particular program has ended. So what this means at the moment is that there are no demonstration models that explicitly advance access to palliative care for older adults. But there are a couple of bright spots that I see, and one is in the last place that you would usually look, the physician fee schedule under traditional Medicare. The 2024 rule published billing codes for services that had not been reimbursed under traditional Medicare before. And services that I think most of us would agree are really important for high quality care of older adults. So that includes navigation services, caregiver education and training, social determinant of health risk assessment, and community health integration services to facilitate access to community-based services that address social risk factors. And then importantly, in the serious illness and palliative care context, a complexity add-on code for time spent with patients who have very complex needs. So again, we're talking traditional Medicare and billing for services, but opportunities to actually get paid for the services that older adults badly need, that either were being provided without reimbursement before January 1 of this year, or weren't being provided at all because of the lack of payment. So I think that's one bright spot. And you can see the American Cancer Society, for example, has spun up over the last year a really exciting new navigator training program. It's called ACS Lion, that I understand from ACS has seen high demand among cancer centers and health systems. So I think we're going to be seeing a lot happening in this navigation space in the coming years. And I think the other bright spot is CMMI's new guide model. There are several people that are seeing the participant list who have been involved with this in some way, shape, or form, or written about it. But the guide model is focused on improving quality of life for people with dementia and their caregivers, and helping people with dementia stay in their homes and in their communities. So it's a package that includes care coordination and care management, caregiver education, and respite care, which to my knowledge is the first time that we've seen, payment for respite care in a package like this. There is health equity is written into this model in a pretty serious way. There are requirements that guide be accessible to historically underserved communities. So attention being paid to applicants to the program who are in those communities and helping stand up new dementia support programs to participate in guide if they need support from CMS for that infrastructure. Required social determinants of health assessments and even a health equity adjustment for underserved beneficiaries. And the guide model also calls for interdisciplinary care, caregiver support. Again, these sort of services that we don't often see payment explicitly written for. So, net, I think the guide model certainly is aligned with what in the palliative care model we think are important wraparound services to promote quality of life for older adults with dementia. And I think on top of that, it's an indication that the folks inside of CMS have really heard and understand advocates' voices around these challenges that older adults and caregivers are facing. So those are two bright spots that I see on the radar.
And I'll talk about two programs, two models of care that I think will have a very big impact on care of older adults. One, of course, is the hospital at home program. This is gaining more and more traction. It is enabling, I always say the worst place for an older person to be is in the hospital. It doesn't help them at all. And too often they come out unable to walk or losing a great deal of their mobility. So hospital at home is really providing full hospital care within the person's own home with their family. It's now has a reimbursement model to follow it, to pay for it. And I think we're going to see it more widely spread. I think one of the more difficult things with hospital at home is across the country, the places where it can be accessible, the places where it can be provided. We know we have medically underserved areas across the country, and hospital at home is probably not feasible in those kinds of places. But where it can be implemented, it's been very successful. And the other one that's very near and dear to my heart is the PACE program, the program of care for I'm trying to think of the A, and it's
all inclusive, I think.
Thank you. The program of all inclusive care for elders, and it really is a wraparound all inclusive program, and I just don't understand why it's not expanded to more states. Why right now it's in 35 states across the country. It is a program for people in this program who might not know. It's a program for, at this point, people are eligible for nursing home care and are dually eligible. And it provides transportation to a daycare center. It provides meals, breakfast and lunch. It provides medical care, nursing care, social workers. It has all of these services available within the center where people go to spend the day. So they may have a cardiologist one day a week. They may have a podiatrist one day a week, a dentist one day a week. It's a managed care plan for the duals. And there was legislation that was passed. There was a bill passed in 2015 to expand the PACE program to include people who were 65 and over and only Medicare eligible, and people under, it's actually 55 and under, because it now covers duals 55 and over, 55 and under who were physically or mentally challenged. And that bill was passed. There was to be a demonstration project with it starting in 2017, and it just has never happened. One of the biggest problems with the expansion of it is the Part D, the Medicare Part D, and how do we incorporate the medication coverage into people who are Medicare only if they're going into this managed care plan, as the PACE program is. So it is a work in progress, but I think that it is a wonderful way to keep people out of nursing homes. They get care during the day, and they are also able to go home with their families overnight. So I'm a proponent, and hopefully we can move that program forward.
Oh, thank you, Tara and Brynn, for that. And right before we move on, a lot of people have been talking a lot about the GUIDE and PACE models. And of course, the GUIDE model stems out of NAPA and, Biden's administration, his executive order to access to higher quality care and supporting caregivers. And people sometimes see these models as one. And so could you both speak about what are the differences? As Tara, you spoke about the population that PACE caters to. What are the big differences between these two models?
Between GUIDE and PACE?
Yes.
GUIDE is directed more for people with dementia. People with dementia are in PACE programs, and GUIDE could be part of certainly could be embedded into a PACE program very, very nicely. So I think they're complementary to each other, and certainly could work together very, very nicely.
Yeah, and as I understand it, and I'm certainly not the expert, but GUIDE really is more of a wraparound services model, whereas in PACE, you're assuming primary care, the people in the program. So there's another difference.
Right.
And one more, GUIDE, the expectation is that the selected participants will be announced any day. So stay tuned to think about where are those services and those programs going to be available to people.
Definitely very exciting news to come, and thank you both for that. Looking at the landscape that we're in now, what are some of the major issues today that are impacting our community-based and long-term services? Really looking at the state and federal landscape, leadership, staffing, regulations. Anybody can start.
Well, I'll start this one. That's a loaded question. And when you said the federal and the state, I mean, we have federal, and then we have 50 state regulations, and they all vary from state to state because the majority of patients, certainly in long-term in nursing homes, skilled nursing homes, are Medicaid eligible. So states have their own Medicaid laws, and so do the feds. So there's a whole piece there, but of course the Fed regulations always supersede the state regulations. But I think, you know, those who are on this call with us must know that day before yesterday, the regulations came out on minimum staffing in long-term care. It is a loaded issue. It is what most of us, I'm a nurse, I believe in quality care, I believe in RN care in nursing homes. I think it does it. We know it improves quality. There's been research that shows that nurses improve quality. This rule is just, first of all, it doesn't go far enough, and yet but even where it does go, it's not really, it can't be accomplished. It can't be done. Back in 2001, CMS did a research study, and they found that 4.1 hours of hours per resident day was necessary for quality care. Now, from 2001 to 2024, the complexity of the residents in long-term care has grown tremendously. And from the 4.1 now, we're down to 3.48, what came out yesterday or day before yesterday as being the regulation for nursing homes. It includes 0.5 hours of RNs, 2.48 hours of CNAs, and then you can fill in the rest of it with LPNs or whatever you want to. But it's in stages. It's not until year 2 that you have to meet the 3.48 hours. In year 3, then the mix has to be appropriate. But this does not include funding, nor does it include access to nurses and CNAs who are available to work in these nursing homes. Most of the nursing homes are vastly understaffed. The turnover of CNAs in nursing homes is over 50%. The turnover of RNs in nursing homes is close to 50%. So we have to do something about the churn of staff. We have to do something about the accessibility of nurses, to have them to come in, and we have to do something about the payment model if we are really going to achieve quality care with appropriate hours in long-term care situations. And I think if we look at assisted living, we're also looking at the same issues. It's a lack of staff, lack of CNAs available, certainly lack of RNs. There's very, very few RNs in assisted living. And accessibility for people to go into assisted living is also a problem in this country, because most of our assisted living is private. In New York City, assisted living costs, private assisted living can go anywhere from $10,000 a month up to $25,000 or $30,000 a month. So it's really not affordable for the majority of people who are 65 and over and in need of some kind of assistance. Brynn, I'll turn it over to you.
Yeah, in the world of older adults with serious illness, some of the most exciting things on the policy front for community-based palliative care are happening at the state level. And this really kicked off as far back ago as 2014. California passed a state law, SB 1004, that required Medi-Cal, the state's Medicaid program, plans to provide a palliative care benefit for eligible beneficiaries. That the California Healthcare Foundation did a lot of work and provided a lot of support to get to that point, and also supported the implementation quite rigorously. But there have been, in the years since, a lot of states that looked at that example in California and are doing advocacy around payment for palliative care services for Medicaid beneficiaries. So Hawaii, where you are, Poki'i, there's been an extensive planning process and a state plan amendment submitted to Medicare for a palliative care benefit, which is very exciting. Washington State legislated development of a standard payment methodology for palliative care services for Medicaid recipients. Oregon, Maine, Maryland, and New Jersey are all states that have undertaken pretty significant action on the way to paying for palliative care for Medicare beneficiaries. So again, philanthropy has played a big role here, kind of initiating those processes, supporting state advocates. The National Academy for State Health Policy has been really instrumental here in taking a focus on serious illness and sharing kind of best practices and advocacy around palliative care payment with states. So there's a lot happening there, and it's exciting. Another place where states are taking action, and it goes back to Tara's comments about workforce. We also have huge workforce shortages in the field of specialty palliative care. So there are a couple of states, Illinois, I believe, being one of them, that have legislation around loan repayment programs for palliative care specialists to try to increase capacity in those states. And then across Medicare, it is all about getting care into the home for older adults with serious illness. So that is where the focus is. So much of that is happening under Medicare Advantage. Medicare Advantage plans can file for supplemental benefits to cover palliative care services for certain of their beneficiaries, but many more plans are covering some kind of in-home primary and palliative care services than have officially filed for that community-based palliative care benefit. So what's happening right now is you see a lot of variation in terms of what services are being provided to those older adults in the home, how much providers are being reimbursed for those services, and plans and providers trying to figure out what is the right service package, the right intensity of services at the right payment. So we don't see standardization in that space, but a lot of focus on trying to figure it out.
And I think
go ahead.
Payment, I think, for home services is also an issue, particularly for the Medicare recipients. It is you must have a nurse, you must have a need for a skilled nurse to have a nurse come into the home. And then if you have a need for a skilled nurse, you're eligible for just a few days, up to 20 days, to have a home health aide help you with your assisted, your activities of daily living. So it's really, there's just not sufficient support for people to stay in the community. And when I look at what went on in COVID and how nursing homes were exposed for all kinds of reasons, legitimate or not, and then we say, well, we have to fix long-term care, but we're not putting money into that. But people can't stay at home because they can't get care. And I always look at someone who's at home and perhaps is even able to have a home health aide there, or even a family member, and they have a urinary tract infection. They can't get treated unless they get to the emergency room, and they can't get to the emergency room if they're not really mobile or someone can't drive them. So now you need an ambulance. The ambulance takes the person to the emergency room. The emergency room, the patient sits in the emergency room all day, and then they can't be discharged. They're admitted. They get up in the middle of the night and fall, and they end up in a nursing home.
Don't forget the hospital-acquired infection that they pick up out there.
And that too.
Right. Right.
We just don't have a comprehensive program to care for our older adults. And that's why I'm such a proponent of PACE, because if that person, but you have to be eligible, you have to be on Medicaid and Medicare in order to get into a PACE program. So the people who are just on Medicare, and I say just because sometimes it is just, you just don't have you don't have sufficient support for services to stay in the community.
Right. It's a patchwork of inadequate, either in duration or in kind of intensity services, and people fall through the gaps in all kinds of ways. And thinking about the population of older adults with serious illness, Medicare Advantage is opening up new opportunities. The flexibility to pay for palliative care physicians or advanced practice providers to come into the home to help, for example, with that UTI, or to help manage symptoms that prevent a crisis that leads that person to have to call 911 is wonderful. But there is a real lack of regulation around what is kind of under the hood with that care delivery in the context of palliative care and Medicare Advantage. So we don't always know, CMS doesn't always know what is going on with those provider subcontracts. And we have to hope that that is high quality care being delivered and not care that is designed solely and exclusively to avoid an expensive hospital stay for somebody who might really need it. So it's an interesting environment, but it is definitely the space where access to palliative care services in the home of some way, shape, or form is growing the most quickly.
Thank you both. As mentioned, that was definitely a loaded question, and definitely appreciated the banter between the two of you and all the information that you shared. You know, there are so many questions coming in the chat and so many questions even from me, especially on with all of that mentioned, where do we even start? But that is another loaded question. So I'm going to step it back and ask, when we have policies coming out, as Tara mentioned, with the new CMS and the hours that they are encouraging or requiring now, when those on the ground can't meet the new policy, or it is not, it's not jiving or with what is really happening, what do service providers do? What are some of the avenues to take to be able to meet regulations?
I think maybe one of the pieces in this regulation that is very important, and long-term care needs support in presenting this, is they have a year to assess their organization and what their needs are for staffing. And somehow those of us in the field should be informing and helping. What does this really look like? How do you staff? What is the assessment? And if you can't meet it, if it's impossible, and there's criteria that says if 20% of the available, if you're below the available workforce by 20% in the RN or the CNA, then you can get an exemption. I think we're going to have to help think about, what does this assessment look like? How do you really begin to assess your long-term care home and say, well, this is what my staffing needs are? I think there needs to be some guidance in how to do that. But perhaps then, to your question then, Poki'i, that we'll get a better grasp on what the needs are. And then we have to figure out, how do we get nurses in there? I always say education doesn't do a very good job in preparing nurses for long-term care. There are very, very few universities across the country who put nursing students into long-term care. And if they do, they put them in their first year to learn how to take vital signs and give a bath. I mean, you're working with what I say are the most complex patients in the healthcare system. They are more complex than what you have in the hospital, because in the hospital, there's a protocol as to how you take care of them. In nursing homes, there are no protocols. These people have multiple comorbidities and very often, very, very often, dementia. And a brand new student going into a nursing home walks into a room with a person with dementia who may see this strange person coming at them, who doesn't really, they sense the fear that this person has. It can be a very, very traumatic interaction of which this young nurse has no idea how to handle. So unless we get our nursing students into nursing homes when they're ready to take care of complex individuals in their final year, introduce them, the teaching nursing home model that's been rolled out in Pennsylvania, that began actually out of the Hartford Institute back in 2008. My predecessor, Maddie Mezzi, started this idea of teaching nursing homes, developing a unit in a nursing home where students could have a very good experience and the staff could learn from the student, a clinical academic partnership. We need to do that all over the country. We need to form teaching nursing homes where students can go into an environment where they get a positive experience. The staff knows what to expect. The faculty member who's in the nursing home knows how to provide support to the student. And students walk out of there saying, I really love this. I want to work in long-term care. So we just need more building the passion in our undergraduate students.
I loved that answer. Also, definitely hit home for me. Brynn, before moving on, do you have anything else you wanted to add?
Yeah, I just wanted to put a fine point on something that you pointed at, Tara, which is the difference in what it means to comply with regulations, either in the nursing home space or in the hospice space, if you're a very small outfit versus if you're larger and you have access to more capital and have a more modernized infrastructure. You can operate more leanly and efficiently and have more resources to be able to dedicate to quality care in one scenario than the other. And regulations don't do a great job of reflecting that diversity. So I think that contributes to the issues in some cases.
I know there's a lot of, there's a lot of advocacy around the greenhouse model and smaller, especially again after COVID, private rooms, a small area, a common community room with single rooms off of it. It's a great concept, but I don't know who's going to pay for it. And I remember someone from CMS saying to me one day, remember, Tara, there is a finite budget, a finite amount of money available. And if you're going to add something, you got to take something away. And I don't know how you can reconstruct some of these nursing homes that are struggling. And I fear that between that kind of activity and even the staffing, this minimum staffing, as much as I want it, as much as I advocate for it, as important as I think it is, I am afraid it will force some of our nursing homes to close because they just cannot afford it. And if they get fined, they're not going to be able to pay the fines.
No, thank you both for that. And Tara, to your point, I definitely agree with the combination or the partnership with our academia partners. When I was a care home operator in Hawaii, our institution became that, exactly what you were talking about, where students came throughout their nursing curriculum to learn how to engage and to change the perception that students had of long-term care and the patients that were in there. And it really worked beautifully, and we got a lot of matriculation, and students came back to work with us after graduation. So, I definitely hear what you're saying. And talking about the greenhouse and small house model, maybe that's for another webinar. We can have them come and let us know how they're changing the landscape. Moving on, what is the impact that the both of you see of the for-profit motive in the provision of long-term care?
7 right back into the fire, huh, Poki'i?
It's hard to believe that 75% of nursing homes across this country are for-profit. I don't think most people are even aware of that. So it is amazing. And I'm biased. I'll share my bias. I do feel that the mission for any for-profit is bottom line. It's making money at the end of the day and giving money back to stockholders, stakeholders, whoever. The bottom line of a mission-driven not-for-profit is, in the case of long-term care, providing the best quality care, best person-centered quality care to residents in that environment. So the missions are different. So I don't know how you can reconcile the missions when they're so very, very different. So I feel that the for-profit is just driving us in a direction which so much of healthcare is today, of big business, rather than meeting the healthcare needs and finding the best ways to do that.
Yeah, I mean, entrance of private equity money in U.S. healthcare means there's a huge motive for short-term profit to be made off of the public good, all over healthcare. But where I feel like most attention has been paid here is in skilled nursing facilities and in hospices. And interestingly, I think you really do see a lot more mention of this in the public press now than you did, even 3 years ago. And I think that's a good thing, because it means, concern over quality oversight. And I don't think that tax status is absolutely determinative. We see non-for-profit healthcare organizations providing poor quality care, and we see for-profit healthcare organizations providing quality care. But the trends that Tara speaks to are true, because profit, where is there money to squeeze out of skilled nursing care, out of hospice care, out of home health? I think we can all guess where those revenues come from. So, I am hopeful that oversight will be stepping up in this regard. MedPAC has been talking about this for years. The OIG has audited several large corporations. Members of the Finance Committee, certainly Senator Warren, have been really outspoken in calling attention to this issue. But it is an issue.
I also think a challenge of it is part of it's been part of the New York State regulations. It's now was built into those federal regulations that 80% of the profit or the income from Medicaid goes into direct care. There's all kinds of ways to do that. So then the question is, where will they take money out of to provide that kind of care? Will it come from not direct care, but other services that do affect the quality of life in those long-term care facilities? So audits are going to have to be done very carefully, and quality is going to have to be watched very carefully by the feds.
Yeah.
Thank you both. At this time, what are the most pressing needs of policy change in our respective domains? What do each of you see as the top policy issues at this moment?
Well, I don't see it. Go ahead, Brynn. I'll follow you. Go ahead.
I was actually just going to keep rolling with the theme that you ended the last question on, which is how we think about quality measurement. In the world of older adults with serious illness, this has been a challenge for a long time. What does quality mean for a very sick patient population that sometimes does need a high level of care, who may have vastly different priorities when they need the care, about staying at home, about getting all of the care that they can get, about what hospice means to them. So it's an issue. And the National Coalition for Hospice and Palliative Care and RAND went through an extensive measures development process over the last several years. And what came out of that process was a patient-reported outcome measure that is, I felt, heard and understood by my provider and my team. And that measure has now been endorsed by NQF, but it's not embedded in any Medicare programs yet. And because we've struggled to develop quality measures for this population, I really think that advocacy around getting this measure integrated across Medicare programs would help us truly get a patient experience in a different way that reflects what matters to patients. And if this measure were adopted into Medicare programs in a way that affects payment, I think that would be the holy grail for that patient population. So I think that will and should continue to be a major focus of advocacy efforts in the palliative care community in the coming years.
And for me, I think we spend far too much money on acute care. I think the transparency of payment to acute care, the insurance companies as the middleman in all of this, I think there's not enough money in the system because so much money is going into acute care. We're not focused on community-based and long-term care, even though 3 or 4 years ago the government came out with this whole program of we need to focus more on community-based services, long-term care. We just haven't moved the dollars at all into those areas. And it's, as I said, there is a finite budget. I fully understand that. And I don't know, maybe it's ageism. Ageism could have a piece of this, that, these are older people, so why worry about that? We can take care of the younger people in acute care. But I think that we have to figure out a way to spend less money in this country on acute care, and certainly more on health promotion, health disease prevention. And people that are very sick when they get old and cost money to the system are because they have not been well, or they have not had good habits throughout their lives. And that is draining the system. So I think we need a more healthy society. Population health needs to be a focus so that there is more money to the entire system, whether you're young or whether you're old. And as the wall of CMS says, whether you're in the dawn of your life, the twilight of your life, or you live in the shadows in between, we need to be able to take care of all those people with equity and dignity.
Thank you so much to the both of you. What a great way to come to the end of this portion of our webinar. And I just want to again say that was such a great dialogue. Thank you to both of you, and to our audience. We thank you for your attention, participation, and being here. And we will now open it up for any discussion. So please put your questions into the chat, and we will be happy to begin to address them. Let me go back up there.
Well, Pat, and there was only one comment besides me, and I was commenting a lot. Somebody was talking about that the government should provide incentives for students to study nursing and go into long-term care, and the incentives to become a certified nurse's assistant, since we have so few of them. And I think that for me, that comment goes into a larger question about workforce capacity, both in long-term care as well as community palliative care, because I think there's questions about workforce capacity in both. Any thoughts about how you feel about are we ready to have more, to provide the care needed in long-term care, in community palliative care, and what we need to do to, do we have the capacity and we're just ready, we just need to fund it, or do we need to develop the capacity? Any thoughts about that?
I think it's fund and develop. I think they kind of go hand in hand. I think we need to, I think if there was financial incentive for nurses that you're committed 2 years in long-term care or community-based care when you graduate, I think that's a real incentive for nurses. But I also think the onus then becomes in the nursing homes and home care. You got to give those nurses the tools that they need. Now, nurse residency programs have been found to be very, very successful in acute care. We at HIGN we're rolling out an online nurse fellowship program, we call it, just to be a little different, for long-term care. These nurses go into long-term care and they really don't know how to take care of someone who's in a nursing home. They don't understand the work of nursing homes. They don't understand delirium. They don't understand dementia. So you can't just put them into a facility or community orientation and then throw them out on the floor and expect them to function, especially when you're working without adequate staff in most situations. So I think we need to worry about recruitment, but nursing homes also have to play a role in retention, and they've got to figure out a way to retain their nurses, to make their nurses feel they're empowered, that they're making decisions, that they're making a difference at the end of the day, and have the support from leadership to do that. So I think leadership has a big part to play in advancing the retention of staff.
And just to state the obvious, a living wage for direct care workers would demonstrate our society's respect for those roles, and make it possible for excellent people to stay in those jobs. Kara's describing, we're at sort of catastrophic levels of workforce shortages on the nursing front and in the direct care workforce. And that too comes back to the money problem in many ways.
Great. There's another question from Melissa Patterson, and she's a geriatric palliative care consult. She says something she's experienced as a geriatric palliative care consult in the hospitals, that PACE does not have a hospital benefit, have a hospice benefit. So she was curious on your thoughts about that, as well as other challenges we have with patients that are in the long-term care residence. And it also can be very challenging to enroll in hospice, especially at the end of life, if they present to the hospital for poor, PO intake or something. Any thoughts about PACE and just general enrollment of long-term care patients into hospice and the difficulties? maybe even the health disparities with that.
Tara, I don't know if you want to start by speaking to PACE.
It's I think if someone is, or if they are enrolled in that PACE program and they are, I guess I'm not clear on the question because I'm reading it. If they're enrolled in the PACE program, I think what Melissa's saying is that even though they are part of XYZ's PACE program, XYZ is not covering the hospice benefit. But if they're Medicare, Medicaid eligible, Medicare does have a hospice benefit. So I guess I'm confused as to why they wouldn't be covered by their Medicare, Medicaid benefit that is available to them as a dual.
Yeah, we certainly know. I have a study which is health disparities in hospice and nursing homes, and we know there's variations in how nursing homes enroll patients into hospice. And indeed, I found out New York has the lowest enrollment of nursing home patients into hospice, of the nation. And so not everybody's getting the same access to hospice care at the end of life. The reasons are not really clear, but any thought about that? Or Brynn, do you have any thoughts about that? I mean, hospice is different than palliative care, but similar spaces.
I think there are a lot of issues with access to hospice, and I will be the first to admit that the phenomena that happen in nursing homes are not what I know the most closely. But for example, if we're talking about unequal access to hospice, whether you have a caregiver who can be at home to care for patients in all of the hours when hospice isn't there is very determinative of, well, A, whether people end up going into a nursing home in the first place, and B, whether a person can receive home hospice. So I think that's a big issue. The other issue in terms of equity and hospice is thinking about, for patient communities who have good historical reasons to mistrust the health system, who may not want to sign a piece of paper saying that they forfeit disease treatment in order to access hospice care. And that was one of the things that there was a hope that VBID might help to remediate. So there's another issue. And then I think a third issue is kind of the flip of both of those, which is inside of a hospital walls, hospitals needing, for reasons of mortality measurements, to get dying patients off of their admission rolls and to keep families waiting while they get a patient, file a patient's paperwork to get them into a hospice bed inside of that hospital. So kind of challenges on the other side, or incentives leading to perverse outcomes on the other side of that equation.
And Melissa just answered. She answered back, and I don't have an answer for you, because my understanding is that you are in a managed care program, which is PACE, and PACE covers the Medicare, Medicaid. So you stay in PACE. If you're admitted to the hospital, PACE has to pay for it. If you're admitted to the nursing home, PACE has to pay for it. So I'm not clear as to what I see you've answered again. But I will be happy to follow up with you. You can get my email. I'll put my email in the chat, and we can follow up.
She says that would be great. I want to go back a little bit to think about the private equity and publicly traded, hospice. It's huge and growing. Home health, huge and growing. And nursing homes, huge and growing. And there's some evidence about, especially with hospice. I mean, first of all, I think, well, there must be some money in this, maybe not, if we're getting these investments from, private equity and publicly traded companies and more for profit. But there is some evidence, like for hospice, there might be some cherry picking going on, that hospices for-profit hospices are more likely to enroll Alzheimer's or dementia patients because they don't need as much care and they live longer, so they get more money. And any thoughts about that, or what this, if the cherry picking is happening, what might be happening with the other people that are not getting into the hospices, or any thoughts on that?
Yeah, there have been some analyses by researchers using publicly available data by OIG, trying to get at, are there significant quality differences between for-profit hospice companies and non-for-profit hospices. One of the trends that you see, for example, is that the longest lengths of stay in both groups are much, much longer for for-profit hospices than not-for-profit, with certain diagnoses, and neurological conditions being one of them. We think about patients with dementia. Cherry picking is certainly an issue that kind of we see it evaluated, and that there are kind of indications in the literature that it's happening. You think about back to my earlier comment, where can you save money on your expenses as a hospice company? Staffing, it's nursing visits. One of the measures that's evaluated is nursing visits in the last week of life. We see variations there. And so there are, it's hard to wrap your hands around. Back to the conversation about how are we measuring quality inside of hospice, inside of skilled nursing facilities. But there are pretty consistent indicators that where there is introduction of private equity money and where there is profit motive, those indicators that we have show real discrepancies between what's happening in nonprofits on the average. Again, there are outliers in both directions, on both sides of the tax status, but on the average, there are real discrepancies between what's happening in the for-profit world and the not-for-profit world.
Great. Thank you. And there's Melissa and has other comments that I've seen that Tracy's going to look at about the PACE and the hospice issue, and Tara, when you look into this, keep me informed, please.
I will keep you informed. Yes, I will.
Thank you. And then there was one other item, about hospice and the over-medication issue. I mean, now that I have this hospice grant, it's clear that some people think that hospice is morphine, Ativan morphine, and that's what they do. And I mean, because
oh, sorry.
But from the community perspective, when I told people I got this hospice grant, that's what some, non-healthcare professionals, like there's some people that are quite feel bad about hospice because they think that's just over medicating their loved ones. And I don't know the research on that or what's going on. I don't know. Brynn, do you know anything, or Tara?
I don't know about the issue of over medication. I'm really curious to find out, and Maureen, I will send you a note if I do. One issue in terms of quality measures for hospice that I just became aware of a few days ago, actually, was a request for information about future strategies to integrate social determinants of health into hospice quality reporting. And I think the domains that were brought up were housing, food insecurity, utility challenges, and transportation challenges. So that's interesting, and not to my knowledge been incorporated into hospice quality reporting programs in the past. Another quality measure that I know has comes up a lot is live discharge, and does it look like an abuse of the hospice benefit because people are being enrolled in the hospice, either were sold a story about what it is that was inaccurate, or just weren't appropriately eligible for hospice, and then are discharged and re-enrolled at a later date. So that's another issue that you see come up in the quality literature, trying to get at what's going on in these different sectors.
Yeah, and I think that I don't think we know enough about cultural preferences or how culture impacts individual preferences for end-of-life issues and what we should do about that. I mean, if somebody doesn't want hospice, because they want their grandmother to have everything. When do we say that, he's dying in the hospital might not be the right thing. It might not be good, and there's better ways to go. And how do we change those? There's so much, I think, with this, culturally competent care that we don't know in this space that we could learn. Any last thoughts? We've got, our hour's almost over, and we're going to the top of the hour, not giving you guys a 5-minute break. It is the end of the day, but last thoughts from any one of you three.
I think everyone wants to hear from them last. My last thoughts really to jump in is just, thank you both for such an engaging conversation. Brynn, I'm the primary caregiver to my father, who's on hospice right now in the end stages of Alzheimer's. And so this discussion, of course, hits home for me as well as my work in long-term care and aging spaces. And Pat, thank you for noting the cultural differences. I think that's always one of my pain points, is especially when hospice came in. Wonderful, love hospice, but understanding like our culture, Native Hawaiian culture, and sometimes the way that my mother feels that care needs to be delivered so that she is living up to being, his spouse, and the way that sometimes our culture, we perceive it as we're asking for help and needing help. But I think, here we've got a good dialogue going, and it's been widely accepted. But, for instance, feeding, that is something in our culture that's very important. And so, having to discuss with somebody how to understand to pull back from feeding can be, very sensitive subject when that's shown how love is given. That's what we do in Hawaii. Every meeting there's food. We eat. So I think just thank you, Pat, for bringing up that point. But Tara, Brynn, so many things you guys talked about, I thoroughly enjoyed, and I look forward to, working with you guys in the future.
Yeah.
Thank you very much.
Tara, Brynn, any last comments?
I would just say there's a lot of work to be done, and we're only scratching the surface. So we'll take an army, but I think with all of us, all of you, all of us, everyone interested in the field of geriatrics and gerontology has their work cut out for them.
Amen to that. What an incredible group of passionate people. I think, we need the money to flow differently, and we all know that, and we have known that. But on days like the day when the guide model is published, I think, okay, people are listening. We are all advocating in one direction, and things can move. So I would just, for all of us, keep up that fight in the positive direction.
Thank all three of you. Thank Bridget and Cadre for organizing it. Thank you to all our participants, and next time feel free to get a little more chatty in the chat box. We'd love to hear the discussion. So thank you all. Have a lovely afternoon, evening.
Thanks, everyone. Have a great afternoon.
Bye.
Bye.